Hello, I'm Dr. Gabrielle Carlson, coming to you from the United States, and I'm really honored to have been asked to present at this conference in honor of Dr. Konstantin Danielian. I'm going to be talking today about a complicated topic called irritability, outbursts, and mood problems in children and adolescents. But before I start, let me just show you where I am and where this conference is coming from. It's a good deal away, but I just thought it would be nice to get a little perspective on the fact that with the wonders of modern technology, I'm right in your living room or wherever it is you're going to be watching this conference from. Let me start off with a clinical grounding. Do you know these kinds of children? Jared, who is 8 years old, is hyperactive and impulsive. He has outbursts where he destroys the classroom when he's given work that he doesn't want to do. He rages for up to 2 hours and gets sent home because he's uncontainable. Or 9-year-old Nikki, who becomes enraged when confronted with situations that make her anxious. She is successfully avoiding school because of this. Or Cody, age 14, who's become so verbally and physically aggressive with his mother that she's had to call the police. This is a new behavior for him. He rarely leaves his room, bathes, or talks to his friends. And finally, Tyreek, who is 10. He bangs his head on his desk, stabs himself with a pencil, and says that he wants to die. What gets him upset is the noise other children make if they sit in the wrong seat or the teacher changes his routine. So let me give you some definitions that will be relevant as you'll see. First, let me talk about irritability, which is called the proneness to anger or sometimes distress. It becomes, it's a normal feeling. I mean, you can feel irritable when your feet hurt or it's really hot outside, but it becomes pathological when the feeling is sustained and the manifestations are destructive. Impairing emotional outbursts are developmentally inappropriate displays of anger or distress, manifested verbally with verbal outpourings, uncontrolled crying, or behaviorally, like with physical aggression towards people or putting holes in walls or banging your head or hurting yourself. The outbursts are grossly out of proportion in frequency, intensity, or duration to the situation or provocation, and lead to significant functional impairment. Now, not all irritability ends in emotional outbursts, and not all outbursts occur in the context of irritability, but I'll be talking today about the occasions in which they're related. So here's a little cartoon of what an outburst looks like. When people talk about irritability, it's that sort of sub-threshold grumpiness that you feel. It can be chronic or, be going on for several hours. But in that context, you're kind of right below the boiling point. This is called tonic irritability. In that context, when something happens that produces some irritation or frustration, the person gets angry or upset. And so you're on this high curve. That's the outburst, which is called phasic irritability. And the thing that's tricky about this is that with people, children and people who are dysregulated, it takes a long time to calm down. And so while you're just sort of calming down, if you're not back to baseline and something else comes along and upsets you, it's easy to get angry again. And so those outbursts can really take a long period of time in order to terminate themselves. How often do these things occur? Well, in the United States, in community studies, it's about 2 to 8% in the community. So they're not rare, and depending on the age of the child, they are more or less frequent. Needless to say, in clinical samples, the rates are much higher. So in a sample of children with ADHD, attention deficit hyperactivity disorder, up to half will have dysregulated outbursts. For obsessive compulsive disorder, again, about half. Children with Tourette's disorder, 25 to 50% can have these explosive anger outbursts. Children with anxiety disorders, children with autism. So as you can see, a number of different conditions can be plagued by irritability and outbursts. In terms of settings where you see these kinds of problems, in my inpatient unit, over half the children needed a PRN or emergency medication because they became so agitated. Over half of the outpatient sample had a history of any kind of outburst, but 16 to 17%, their parents were there specifically because the children had severe physical outbursts that were happening at least weekly. And in our emergency room, about a third of the kids were brought in for these outbursts, many of them by the police. We are talking about children ages 12 and under who get so out of control with these outbursts that the police are called to bring them to the emergency room. I don't know the degree to which this is a problem in other countries, but this is certainly an issue in the United States. In terms of what children do when they have outbursts, let's face it, most of us, and most kids, when they get upset, they argue, they whine, maybe they sulk. Some of them will slam a door or punch a wall. As they get madder, they'll swear or shout or insult you or throw things, threats of violence. Kicking, hitting, doing something physically aggressive is happening in about a third of kids. About 20% might be hurting themselves. And maybe 1 out of 6 of them, a parent will say the child needs to be physically restrained because he's hurting himself, somebody else, or damaging property. These things can happen in kids who are pathologically plagued with these outbursts. They happen weekly or daily in 40% of the cases. And these outbursts, as I showed you from that cartoon, can last quite a long time. So more than half the sample, the outburst will last about 30 minutes. Now, the point I was making before when I was talking about clinic samples is how transdiagnostic irritability and outbursts are. So this is supposed to be a graphic of the elephant, you know, the aphorism of the blind man and the elephant. Well, it depends on what disorder that you're studying, what you call these things. So in a number of conditions, it's simply called irritability. So bipolar disorder or post-traumatic stress disorder or maybe even oppositional defiant disorder or the relatively new disorder, disruptive mood dysregulation disorder, we talk about irritability. But in anxiety, they're called catastrophic reactions. Parents will talk about that. Or meltdowns in autism, or rages in Tourette's disorder, or reactive aggression and conduct disorder, or mood lability in ADHD. So the point is, these things are really pretty common in these various different conditions. The diagnoses that are most common in the conditions, at least in clinical conditions that I've studied here in the United States, about 80% of outpatients will have attention deficit hyperactivity disorder. It's not uncomplicated though. Most of the kids will have comorbid oppositional defiant disorder. Many will have mood or anxiety disorders, learning or language disorders. A separate bunch of kids might have an autism spectrum disorder. Sometimes they'll have disruptive mood dysregulation disorder. Rarely they'll have bipolar disorder, but ADHD is the most common. And on the inpatient unit, for our children's unit at least, even more of the kids have attention deficit hyperactivity disorder with all of those various comorbidities. And so finding one condition that necessarily accounts for the outbursts has been elusive. One of the things that we have just managed to get adopted by at least the DSM-5, which we use in the United States at least, is a way to code these outbursts. So we can now give them a code. The way you give somebody a diagnosis, you can code them for their impairing emotional outbursts. The code is R4589. And the outbursts are defined as displays of anger or distress, manifested verbally by verbal rages or uncontrolled crying, and behaviorally by physical aggression, towards people, property, or self that lead to functional impairment. You don't use it in children who do meet criteria for disruptive mood dysregulation disorder or intermittent explosive disorder. And the reason that it's useful is that when you get a child who is coming in for attention deficit disorder or anxiety disorder or depression or whatever, and their problem is outbursts, you can signal that that's what the problem is by adding the R code to the diagnosis. So if we go back to the children that I introduced you to at the beginning of this talk, we have Jared, who was hyperactive and impulsive and who had long temper tantrums and trashed his room. He would be given the diagnosis of F90.2, which is ADHD combined, and the R code 4589 for his impairing emotional outbursts. For Nikki, for instance, who became hysterical when she had to leave home and go to school, she would get a separation anxiety disorder, F93.0, with an R4589 to signal her outbursts. Cody, who had become withdrawn as well as irritable, would be diagnosed with a major depressive episode and outbursts. And Tyreek was diagnosed with an autistic disorder and impairing emotional outbursts. So the differential diagnosis of irritability, here's the way I think about that. If the outbursts are very rare, you're not looking at anything like disruptive mood dysregulation disorder or bipolar disorder. So we're not going to worry about rare outbursts. If they're frequent, which are the ones that come to clinical attention, the next cut is this a change from the child's previous self? Is this behavior representing something new? He hasn't always been like this. Then the next cut is whether it's a child we're talking about or an adolescent. If it's a child, your differential diagnosis is a stressor or trauma, learning problems or bullying in school, family problems or abuse at home, anxiety disorders or catastrophic reactions. So those are sort of the first cut if this is a new problem. For adolescents, if it's a new problem, then you're most of the time ruling out a mood disorder, depression, mania, or anxiety disorder or trauma. And now, of course, we start seeing drugs or psychosis as being possibly accounting for some of these outbursts. So that's if they're frequent and it represents a change in behavior. If the behaviors are chronic, they've been there for most of the kid's life, then the next cut is this child irritable between the outbursts, or do the outbursts only occur when the child doesn't get what he wants? If the child is irritable between outbursts, then you're looking at possibly disruptive mood dysregulation disorder. If the child is fine until he's frustrated, then most likely you're talking about attention deficit hyperactivity disorder with oppositional defiant disorder. And in either case, you can have comorbid autism spectrum disorder. How do you evaluate irritability or outbursts? I don't know whether these slides will be available to you because it's probably difficult for you to write all of this stuff down. But if you're a member, I think even if you're not a member of the American Academy of Child and Adolescent Psychiatry, you can go to our website, acap.org, and basically you can click on Youth Resource Centers of Emotional Dysregulation, and we have rating scales that you can use. Now, the best interview to use is the Development and Well-Being Assessment, which is the DAWBA. Free comprehensive rating scales are the Strength and Difficulties Questionnaire. A specific rating for irritability is the Affect Reactivity Index, or ARI. A specific rating for emotion dysregulation is the Emotion Dysregulation Inventory. And the specific rating for outbursts is the Emotion Outburst Inventory. So as I said, you can get all of those from our acap.org website. What kind of interventions do we have for outpatients with irritability? Well, it depends on the primary diagnosis because, as I've been telling you all along, this thing is transdiagnostic. So if we look at medication management in general, the recommendations are to treat the primary disorder and add another medication where necessary. Medications for aggression have an effect size of about 0.6 to about 0.8. An effect size, as you may recall, is basically a way of looking at one standard deviation on a rating scale. And so a medication will improve the child, if you're lucky, up to, well, maybe 3/4 of a standard deviation. Psychosocial treatments, the best data we have are for parent training and behavior modification, in which case there are numerous meta-analyses that have been done with it. The standardized mean difference is, which is like an effect size, is about 0.4 to 0.6. So it helps not quite as much as medication, but it's the best treatments we have. There are less data for cognitive behavioral therapy, collaborative problem solving, and anger management, but those have also been used. And if you've got a child in school, there are also functional behavior analyses with behavioral intervention plans that should be available in schools. Now, in terms of what treatments we have for ADHD with irritability and aggression, they're not exactly the same, but they're related. And the data that we have is on aggression, because irritability has only recently been recognized as something that we're going to contend with. And even then, at least in the United States, the Food and Drug Administration only recognizes it in autism. So there have been studies that have been directly examining the effect of medication on ADHD, looking at irritability either as a direct problem or as a side effect of the medications that you might be using. Now, I'm told that in Armenia, at least, you have not been approved, or stimulant medication, which is basically the cornerstone of treatment for ADHD, is either not in regular use or has not been approved yet for use in Armenia. And so I was torn about whether I should put these data in if you can't use them. But you know what? This is something you're going to need to really change, because it is about time to come to the 21st century in terms of treating attention deficit hyperactivity disorder, and certainly treating the mood dysregulation that goes along with it. But in any event, if you look at old meta-analyses about what stimulants can do to reduce aggression, the effect size is really high, 0.84, almost a whole standard deviation. Even covert aggression, in other words, not anger-related, but more cold-hearted aggression, is reduced. And recent data continue to support the effectiveness of stimulants in overt aggression. These are just some graphics to show you the kind of reduction we're talking about. You can see this is the child and his level of aggression before treatment. This is measurement from the teacher in red, or from the parent in blue, or from the observer in green. And as you can see, there's a sizable reduction over the course of time. The observer is just looking in class at one particular moment. So you can see the effect that that has. This is some other data from the Multimodal Treatment of ADHD study, which is the landmark study of almost 500 kids who were treated with stimulants and behavior modification, or just community treatment. And here you can look at very specifically ADHD and mood dysregulation. These are kids in the lower graphic here. These are kids with uncomplicated ADHD, and this shows improvement on stimulants over the course of 14 months. These are children with ADHD and mood dysregulation, and the graphic tells you two things. First of all, kids with ADHD and mood dysregulation have worse ADHD to start out with. Their rate of improvement is the same as uncomplicated ADHD. But because they start out sicker, they don't clean up completely, even at the end. Okay, so this is, if we were to use a fever analogy, these are people who have a temperature of, we'll say, 38 degrees Fahrenheit, and you take an anti-fever medication and your temperature goes down to 37. These are people who have a fever of 40 or 41, and they take the same fever-reducing medication, and they're better, but their temperature may be 38 or 39 at the end. So improvement, but not cure. These are data showing improvement in rule following when you combine medication with behavior modification. And what it says is that there is a relationship with dose. So if you use a low dose of stimulants, you get this much improvement. If you use a more effective dose, you get a better reduction or a better rate of kids doing what they're supposed to be doing. And this is a study that was just published over this past year, which is, in my opinion, also a landmark study. And basically what the investigator did here was to give a large sample of kids, almost 200 kids, who came in with ADHD and these outbursts of aggression. He gave them optimized, in other words, he did the best he could with giving them stimulant medication. And what you can see is half of the sample really improved. They improved so much that they said, I don't need to be in the study anymore. My child is fine. The other children who didn't get that well got randomized to continued medication, and they got randomized to I guess you can't see it on the slide. They got randomized to valproate, which is an anti-seizure medication, or risperidone, which is an antipsychotic medication, or placebo. And the red and the green represent drug and the gray represent placebo. So as you can see, those medications, while you're taking a stimulant, separated from placebo, but they never got as well as these kids over here. So this is probably a subtype of problem here. Oh, there we go. Okay. Are there non-stimulant ADHD treatments that are effective? Well, there are surprisingly few studies of alpha agonists like clonidine and guanfacine, and they're not hugely impressive. Guanfacine was not better than placebo in reducing irritability, at least in autism. It was helpful in kids with ADHD and oppositional aggressive behavior, but if it didn't help the ADHD, it didn't help the aggression. And clonidine, and used at a 0.1 milligram morning and evening dose, did help somewhat. An Italian registry study that was published a few years ago found that, in fact, atomoxetine made irritability worse. So the current approach to treatment is optimizing responsive ADHD, usually to a stimulant, and adding a second medication if necessary. And the second medications can be an antipsychotic, a mood stabilizer, maybe an antidepressant or an alpha agonist. In terms of the second generation antipsychotics, we have the best data for risperidone and aripiprazole. There are a number of double-blind placebo-controlled studies that basically show that there's a significant reduction in aggression and irritability. The other atypical antipsychotics have less data because the initial studies were not very promising for those medications. As far as mood stabilizers are concerned, like lithium or valproate, you've got studies that show that by themselves, divalproex or valproate is not effective or not very effective. Oxcarbazepine wasn't useful. Lithium alone has been helpful in hospitalized kids, but by and large, atypical antipsychotics, at least risperidone, was comparatively much more effective than either lithium or valproate. For antidepressants, I can only tell you that in one of the studies, adding fluoxetine to placebo or lisdexamfetamine, a stimulant, did not improve anything, didn't add anything to it. A recent NIMH trial added citalopram to methylphenidate, and it provided a non-significant trend at the end of treatment. So it was helpful in some kids. So in terms of the outburst algorithm for treatment, in terms of thinking about it, if you've got episodic outbursts that may be caused by mania, bipolar disorder, then the first treatment is, of course, to treat the bipolar disorder and mood stabilization. And if the child has ADHD and dysregulation, then you add that treatment afterwards. If the child has ADHD and ODD with outbursts or even disruptive mood dysregulation disorder, you optimize the ADHD treatment with stimulants and parent training. And if that's all they need, great. If their ADHD improves and the outbursts continue, then you add anti-aggressive and maybe mood stabilizing treatments. If the ADHD is worse, then it's really tough to treat those kids, and you're basically trying anything you can. In terms of the other kinds of psychotherapies that there are for irritability, the best data we've got is for parent training and behavior modification. Anger management and CBT is useful basically in what's called aberrant threat processing, where the child misperceives the size of a threat and reacts to what he thinks is there and not what's there. Collaborative problem solving is maybe helpful for cognitive inflexibility. Dialectic behavior therapy has been useful for adolescents, though interestingly enough, it hasn't been all that useful for children who've got outbursts. This is a study where the investigator really threw the book at the kids. They had the parents had psychoeducation and behavior modification. The children had group therapy. They were all treated with stimulant medication and compared to a community group. And the bottom line is that this did improve the kids while the kids were in treatment. But as soon as the treatment stopped, I'm afraid that there was backsliding. So you're not treating an acute problem with this. You're treating a chronic problem when you do interventions for mood dysregulation. In terms of treating the actual outbursts, there is no quick fix. Again, we go back to our friend behavior modification and limit setting. PRN medication, as needed medication, are widely used, but there are no placebo-controlled studies to demonstrate that they shorten the episode. And the problem is that it takes about 30 to 60 minutes for oral medications to work. And by that time, the outburst has calmed down by itself anyway. So it's really been difficult to intervene with that. In terms of follow-up, these children are unlikely to develop bipolar I disorder. They may continue to have mood and anxiety disorders. Children who have severe chronic irritability are likely to remain very significantly impaired, so that the rates of ADHD and ODD persisting are greater than mood disorders. The ADHD and ODD attenuates, but this is compared to what they used to be, not compared to other people. Kids with ADHD and ODD and mood dysregulation don't evolve into people who only have depression or anxiety. Their comorbidities continue, and disruptive disorders really continue to be a problem. So just to review, irritability is a combination of the feeling, an internalizing feeling called tonic irritability, where the child feels easily annoyed, angry, grumpy, and the follow-up would suggest maybe in those cases you have an internalizing disorder. Externalizing problems are phasic irritability. It's what the child does, which is outbursts, yells, screams, damages, hits, kicks, spits. Follow-up does not show bipolar disorder. It does show persisting externalizing disorders. So in conclusion, irritability is a mood, the presence of which is defined by behavior. Outbursts represent severity or the developmentally inappropriate displays of anger and distress, manifested verbally or behaviorally and grossly out of proportion in frequency, intensity, and duration to the situation of provocation. The duration of outbursts is about 30 to 45 minutes. The more severe and persistent, the longer the problem lasts into the future. Diagnostically, most children have attention deficit hyperactivity disorder, complicated by externalizing, internalizing, and learning and language disorders. And you can add the R code to identify outbursts as the evaluation and treatment driver. We definitely need better outcome measures for treatment programs, and we need better treatments. So thank you very much for your attention.